So today we're going to be talking about diagnostic challenge in asthma. Just the outline, we will briefly talk about the prevalence and the economical impact of asthma, talk about the diagnostic criteria for asthma and challenges, and then just briefly mention what other things to consider when diagnosis becomes challenging. Just briefly, asthma is a chronic inflammatory disease of the airway. As of the most recent, I think 2010 CDC report, is about 22 million people with asthma. It's been increasing in prevalence over the past few decades, and just as a historic reference, the first clinical practice guideline for asthma education and prevention was released in 1991. As you can see, the prevalence has been getting significantly prominent. In 1980, the prevalence was 3.1%. Now, in 2010, it's 8.4%. However, despite the increasing in prevalence, the number of deaths from asthma has declined. Fewer patients report limitation in their activity, and an increasing number of people has actually gotten asthma-related education. This is a graph from 2001 to 2009, and as you can see, the mortality has declined, and then outpatient emergency room and urgent care visit has actually kind of stabilized. Of course, the challenge with this epidemiologic data is how it's collected. It's usually, people are given questionnaires, question about have you ever had a diagnosis of asthma or have you ever had the symptoms of asthma, and that seems to correlate, especially in some population, with awareness. So, and over the past few decades, asthma awareness has gotten significantly more because from national perspective, there's increased asthma education, and then from pharmaceutical perspective, there's new medications coming up in the market, and then the more medication, more advertisement, more awareness. With that, we go to the economic impact. So in 2007, it cost about $56 billion to manage asthma patients, about 3,000 per person, not to mention number of work missed and school missed. This is a 2013 New York Times article really showing how challenging it is to manage patients with asthma, especially the cost of asthma when you're not insured. Just a brief example would be with $250 you can buy 2 QVAR inhaler in the US, and you can buy 37 in Greece. And this, $250 you can buy 1 in US at Ver, and then 7 at Ver in France. So when you had a problem like this, really have to say, there is increasing prevalence. There is increasing prevalence. At the same time, the economic impact is significant. So really, louds the importance of accurate diagnosis. What are the diagnostic criteria for asthma? It's based on history of, patient having episodic symptoms of airflow obstruction or some signs of airway hyperresponsiveness, followed by objective assessment and then exclusion of alternative diagnosis. Now, you may not be able to exclude alternative diagnosis in the first encounter, but it should always be in mind when patients are acting or responding not the way you want them to respond for asthma management. What does diagnosis entail? Basically, it entails a detailed medical history, physical exams, spirometry being the most common objective assessment, and then other studies as needed to either confirm or exclude asthma. Just as far as history is concerned, usually typical history of asthma would be episodic symptoms with periods of symptom-free, symptoms that get worse at night, or exposure to irritant or exercise, infection, and then also family history of asthma would be more helpful, and then as a manifestation of allergic disease such as allergic rhinitis and eczema. As far as physical exam, most of the time it's normal, but in someone who's having uncontrolled asthma, you might see hyperinflation of their chest, sounds of wheezing, prolonged exhalation, and then you might see signs of allergic rhinitis, like nasal polyp, mucosal swelling, and then other skin disease. just a little more about wheezing, because really when you look at the mechanics of wheezing, wheezing is a sound produced when two opposing walls are oscillating near each other to the point of closure. It can originate along any airway. Even in some papers, they describe a stridor as an inspiratory wheezing. So it's just basically it's a sound that's created. Now, what is considered a classic wheeze for asthma is it's high-pitched musical that is discontinuous. The key thing being a discontinuous that starts and stops at different times during the respiratory cycle. And I'll give you an example of that. And then, so we'll listen to this one and we'll compare to the monophasic wheezing that is still a single-pitched, continuous wheezing that start and end at the same time during the respiratory cycle. So as you can see, there is a little more continuity in the monophasic, because that tells us in terms of the difference. Because monophasic wheezing you'll see with localized airway obstruction like foreign body or endobronchial tumor or even a subglottic stenosis. And then the most important thing is just absence of wheezing doesn't necessarily mean it's a good thing. It could be really bad. And then as the old expression goes, all that wheeze is not asthma. So as far as PFT, usually asthma patients who are not symptomatic may have a normal PFT, but typically you may see a low FEV1 to FVC ratio or FEV1 to FV6. And then FEV1 could be normal or low. With short-acting bronchodilators, you would like to see evidence of reversibility, which we already know that 200 ml and 12%. What I didn't know about is a 10% increase from predicted FEV1 being used as an alternative. Other testing we do usually, we always add diffusion capacity because it tends to help us sometimes in differentiating with from COPD. But lung volume sometimes with elevated total lung capacity, residual volume, or signs of evidence of lung air trapping would be helpful. Flow volume, we don't see it more often, but you can see that this is fixed upper airway obstruction. This is just typically the scooping of the expiratory phase, which you see with emphysema, or even in someone who's having uncontrolled asthma, as opposed to someone with intrathoracic obstruction, where you see the flattening of the expiratory loop, and then with extrathoracic, you'll see flattening of the inspiratory loop. And of course, when everything fails to show, we do the methacholine challenge test, which is a way of assessing the bronchial hyperresponsiveness. However, that does vary with the severity of the disease. So if the patients have well-controlled asthma, you may have a normal bronchial hyperresponsiveness. It has a good, excellent sensitivity, but its specificity is limited because you might see it in other diseases like COPD, allergic rhinitis, or bronchitis. So really, when you order methacholine challenge test, you really have to put it in the context of your pre-test probability for asthma. So, if your pre-test probability for asthma is very, very low, you should probably not order it. Just a little more about methacholine challenge, just the absolute contraindication. Someone has FEV1 less than 50% or less than 1 liter, recent heart attack, uncontrolled hypertension, or recent aortic aneurysm. I would also add, if you're not able to perform good quality spiral, I think you shouldn't have that done. This is just to show how long you have to hold the medication for. Most of the time, the short-acting is 8 hours, the long-acting 48 hours. Now, this is not required. You can continue using your inhaled corticosteroid. However, you have to put that in the clinical context that it might decrease your bronchial hyperresponsiveness. So when you get a negative test, you have to put that into consideration. Patients should also be advised not to have coffee, tea, cola, and chocolate, just so that it doesn't affect. most of the research papers use 8 milligram per milliliter PC20. Basically, PC20 is a concentration of methacholine required to decrease your FEV1 by 20%. And most studies use 8 milligram per milliliter as a cutoff for positive or negative. Now, this graph is really not showing that like there is a number you calculate for post or pre-test probability, but it's just want to give a conceptual understanding of what the methacholine challenge is. It really is a way of filling the gap between the pre-test and post-test probability. For example, if you have a patient, we say, okay, my pre-test probability is lower. I don't think he has asthma, but his pyro is negative. He has no evidence of obstruction. And you order a methacholine challenge test and it comes negative, then it kind of confirms your suspicion that this patient doesn't have asthma. If you have a high pre-test probability and it becomes positive, your post-test probability is so high that you say, okay, that confirms. The ambiguity comes when the patients are in the middle, when you have sort of some pre-test probability, but the methacholine challenge is negative. In some cases, when people have seasonal asthma, like where in between seasons they have no symptoms of bronchial hyperresponsiveness, then they may have a normal methacholine challenge. So now that we see that the diagnostic criteria for asthma include three things: history, objective assessment, and exclusion of other diagnosis. So when we talk about diagnostic challenge, then it has to come out of those three. Of course, history is not a big problem. Most of the time the problem we see is that people not getting objective assessment and then other diagnoses not being excluded. Just to kind of stress the point, this is a case, I think a few years back, presented on a New England Journal of Medicine about a 38-year-old female who has history of GERD, allergic rhinitis, and depression, who presented to her primary care complaining of shortness of breath, fever, and cough after delivering her third baby. She was given a course of antibiotic for suspected tracheobronchitis. Her symptom improved. However, soon after she returned with cough, shortness of breath, and wheezing that gets worse at night. She was a previous smoker. When on exam she was morbidly obese and she has diffuse wheezing. Given her history of intermittent episodic wheezing that gets worse at night, physical examination finding of diffuse wheezing, she got a diagnosis of asthma. She was started on inhaled corticosteroid and long-acting beta agonist. Over the next 5 years, she continued to have exacerbation at least once a year. She was hospitalized many times. Once she moved from Florida to New Hampshire, her symptoms actually got progressively worse. She's now getting hospitalized every 3 to 4 months. She did have some history of allergy, so she was started on daily oral corticosteroid and even omalizumab. But despite that, she continued to have worsening symptoms. She presented to another hospital, and at that time they did a CT of the chest, which was non-significant, and her PFT is fairly normal. She underwent bronchoscopy, and this is what they found during inspiration and expiration. You can see there is significant collapse of her airway. So you can imagine when she has tracheobronchitis and mucosal swelling and edema, how further narrow it can get. And she did have a dynamic CT study that with exhalation and inspiration, and you can see how much of her airway got collapsed. And she did underwent rigid bronchoscopy. Stent was flashed, didn't tolerate it, and had to go through surgery to fix it. But at 6 months, she was doing fine off most of her medication and getting back to her life. So, as you can see, that once patients get labeled with diagnosis of asthma, they're stuck with it. There is a trend to see asthma as a syndrome rather than as a disease. So if patient presents with a certain group of symptoms, they're called asthmatic. But we all know that signs and symptoms of asthma is neither specific nor sensitive. Even within a patient, it varies over time. And there's there's a lot of other diseases that have similar presentation as asthma, but completely different way of management. So, as we talked about again, your diagnosis, the diagnostic criteria for asthma involves presence of episodic symptoms that due to airflow obstruction or bronchial hyperresponsiveness, objective assessment showing airflow obstructions that's at least reversible, and then alternative diagnosis being excluded. Again, as I mentioned, at the initial evaluation, alternative diagnosis may not be excluded, but it should always be kept in mind, especially when patient continue to get worse. So let's talk about the objective assessment and the challenge with that. This is a study in Spain. They looked at physicians, primary care physician, and they asked them, like, your 10 patients with COPD, just send us all your documents. They looked at 251 primary care physicians with almost 2,000 patients with a diagnosis of COPD, and almost 40% of them never had any pulmonary function test done. So we have a diagnosis of COPD without PFT. So then you ask the question, okay, if we're diagnosing patients with COPD or asthma without any objective assessment, how often are those diagnoses correct? And this is a study done in Sweden. Basically, they went to 2 primary care physicians in a small town. They asked them to look at their patient with a diagnosis of asthma. They found 86 patients with a diagnosis of bronchial asthma. They were seen by a physician and a nurse. And then they underwent testing. They looked at them again. They said, okay, history, physical, PFT done with bronchodilator. If they're positive, then they maintain their diagnosis of asthma. If they have reversibility, but not significant reversibility, they treated them for uncontrolled asthma for 2 weeks with a steroid. And after several weeks, they repeated their spirometry. If they become positive reversibility, then they maintain the diagnosis of asthma. If they didn't, then they undergo methacholine challenge test. And if it's negative, then their asthma is excluded. And as you can see, out of the 86 patients, 29 of them didn't have a diagnosis of asthma, and the most common one being COPD. And when you look at people older than 50, almost 50% of them have the wrong diagnosis. This is another study done in Canada. They looked at patients diagnosed with, physician diagnosed patients with a diagnosis of asthma, and 52% of them never had any pulmonary function test. They don't remember having that. And out of the 90 patients, 41% could have a negative spiro and methacholine challenge test. And then of those 41%, 62% of them were taking asthma medication. Another big study in Canada, just following, it's a longitudinal study of 246 obese patients and 254 non-obese patients. They were recruited from different cities. And I'll talk about the detail of the exam on the next study. But out of this patient, almost 30% of a patient have no asthma, and it's the same in obese or non-obese patients. So again, the idea that obese patients tend to have more asthmatic symptom or more diagnosis of asthma, that's incorrect, maybe not all the time correct. So then what's the barrier? What's the problem with making the diagnosis? And some papers suggest that primary care physicians are too busy. They just, if you don't have PFT lab available, and when you can't just treat with albuterol and diagnose based on their response to the albuterol, why do it? But the problem comes to the pulmonologist, because when the patient doesn't respond the way they're supposed to, then they will be sent to pulmonary function, to the pulmonology office. Then what do you do? When someone comes in with existing diagnosis of asthma, do you say, okay, you don't have asthma, do you continue the same medication? And currently there is no validated protocol saying this is what you should do. And there is an idea that once patients are on prolonged inhaled corticosteroid, when you do a bronchial hyperresponse, when you do the methacholine challenge test, it's really not helpful, because if they're positive, is it because they if they're negative, is it because their asthma is well controlled, or is it because they didn't have asthma in the first place? So, and then of course, all the time we're concerned about holding a treatment and worried that they can have a significant asthma exacerbation. Go ahead. It doesn't rule it out, and I'll talk more about it. But I think if they are symptomatic, again, the question is, have you for sure excluded other causes of their symptom?
I think the more important way to answer that question is you look at the four classes of asthma: mild, intermittent, mild, persistent, moderate, persistent, severe persistent. Your spirometry does not even become abnormal in the moderate persistent category. That means that people with mild, intermittent, and mild persistent corticosteroids, by definition, still have normal spirometry. Now, if you look at the breakdown of the population, the population percent falls into those categories. 85% of the asthmatics fall into the mild, intermittent, and mild persistent category. So, by definition, 85% of your asthmatics out there, the milder ones, are going to have normal spirometry. So, it's not really much help.
It does beg the question of how do you actually rule out the diagnosis of asthma?
Right, and
then the methacholine he's talking about, the guidelines are being readdressed, they're being defined again, because in the 91 guidelines, they clearly stated that if you have a negative methacholine challenge test, that rules out asthma. Well, there's been a number of publications since then, including one of our own fellows here, several years ago, looking at several hundred patients, and we found in 18% of our patients, several hundred that had negative methacholine challenge tests, had proved to be proven. I think the part that was really doing the trade
Right now, I'm not sure where you're going.
Okay. But we found that, like, over the next several years, through doing charts, 18% of them turned out to have chronically definitive asthma, even though they had negative methacholine challenge tests. Which then brings up even another question: how do you do the methacholine challenge test? There's two recommended methods. There's one you do the vital capacity method, or the 2-minute tidal breath method. Again, they said those were equivalent. We published a study in the Journal of Asthma that showed that by just changing methods here from the 2-breath tidal breath method, from the 5-breath vital capacity method, we doubled the positivity of methacholine challenge tests 3-year period to another 3-year period, looking at a total of 700 and some patients. So with a lot of this, it's, I think kind of the most important point is getting at it. It looks like a duck, it quacks like a duck, you may treat it like a duck, but make sure you rule out the other things that might look like it.
all right. And I guess that's the same thing with the methacholine challenge. It has to be with your pre-test probability. If you really suspect patient have asthma, and the methacholine challenge is negative, along with working out different causes, I think you might continue treating the way they should be. So this is a 2010 study in Canada again. Now, this is the study of just the paper I presented that was done in 2004. They actually went back and did a secondary analysis of those patients to say, what does it require? What definitely you need to do to rule out or confirm asthma diagnosis? So again, they looked back in the paper and they included patients that are older than 15, diagnosis of asthma as reported by a patient, not the excluded patients who are possible at risk for COPD or taking long-term oral corticosteroid, or they're not able to do the long-term function test. This is what they did. So this is a study from the 2004. At visit 1, they did a pre- and post-bronchodilator spirometry. Now, as you can see, they're using 15% rather than the 12%, but 200 ml or 15% is what they're using. If that is positive, they confirm the diagnosis of asthma. If that is negative, what they did was they actually did a methacholine challenge test. If the methacholine challenge test is positive, they confirm asthma. If it's negative, then they decrease the dose of the inhaled corticosteroid by half, and they stop all the other, like the single layer or other oral agents. Then they tested them again in 2 to 3 weeks. Now, on that visit, they repeated the methacholine challenge test. If it's positive, again, confirm asthma. If it's negative, you completely stop their medication, repeat the test in 2 to 3 weeks. Then with no medication, if they're negative, then you say they don't have asthma. If they with lower medication, if they are positive, then you confirm it again. So of those 496 patients, asthma was confirmed in 70% of the patient, and 30% of the patient were excluded, didn't have asthma. It only took 2 visits to confirm asthma, almost in the 95% of the patient. And almost 90% of the patients didn't have to do anything with their medication while they were on inhaled corticosteroid. Now, there was a previous study that says, well, if it's negative, that's a problem. If it's positive, it confirms your suspicion. But if it's negative, is it because their asthma is well controlled, or just they didn't have asthma in the first place? But in this case, 90% of the time, 90% of those patients were confirmed without their inhaler being reduced. And then just their secondary analysis also showed smokers and patients with lower APV1 tend to be confirmed earlier. Of course, the main concern is that stopping medication and worrying that the patient will go into asthma exacerbation. Of the 499 patients, 2 of them has asthma exacerbation, but that was before the tapering, but only 4 has when their inhaled corticosteroid was it stopped, and then 2 have after the medication was stopped. And then at 6-month follow-up of the 142 patients in which asthma was excluded, 60%, almost 66% didn't require any medication for asthma or medical care for asthma. So really what to get out of this is that, most of the time when we get asthma patients, I think their asthma diagnosis can be confirmed. I think it's not, they do recommend slowly tapering the inhaled corticosteroid rather than abruptly stopping. But I think it should definitely be confirmed before pursuing further care. So then the other problem comes is, we treat them for asthma and then they're not responding and then they're getting worse. So what do we do with that? So now I think the new consensus is trying to kind of avoid all this nomenclature of asthma, like severe asthma, brittle asthma, difficult to control asthma, steroid-dependent asthma. Basically, they're trying to cluster them into called refractory asthma, which is about 5% of the total asthma patient. Key point is that well-controlled asthma doesn't necessarily mean it's not refractory. I think the question is, what does it take to control them? So this consensus again describes if you're requiring steroid for more than 50% of the year, or if you're requiring high dose of inhaled corticosteroid to get a mild to moderate persistent asthma level control, and then that is not a well-controlled asthma, that's a refractory asthma. And then at the bottom you can see that if you have one or both major criteria and 2 minor criteria, which includes ER visit, or if your symptom gets worse when you decrease your prednisone dose to less than 25%, or you have near fatal asthma, or you're having symptoms every day, that's a sign that it's refractory asthma. So what should we do when we have them? Again, I think it should always be confirmed that we're dealing with asthma. Other diagnosis should be excluded. And then, of course, evaluate and treat any other things that can be making their asthma control difficult, including like inhaler technique, environmental factors, and then optimizing their asthma treatment. And this is what they recommend. Again, just confirm asthma, look at differential diagnosis with COPD being the most common, but cystic fibrosis, vocal cord dysfunction, sleep apnea, vasculitis, cardiac heart failure, and then ABPA. Of course, the recommendation is to do skin test, CT scan, pH monitoring for reflex disease, and CT chest or chest X-ray to look out for any infiltrate to suggest other disease or other complication. So again, asthma mimickers to really consider: COPD, vocal cord dysfunction, foreign body. I think up to 25% of patients, they don't remember aspirating anything. And then, as we saw earlier, they tend to have typically a localized wheezing, but they can actually have a diffuse wheezing. We saw a case report. The case report of tracheomalacia causing a significant problem. And you'll hear of a lot of cases of young patients with like endobronchial carcinoid who have difficult to treat asthma. They'll have chest X-ray or maybe their CT show some in the bronchial, and they end up getting diagnosed with those. So in summary, asthma is a clinical diagnosis. It really is variable. Asthma patients are heterogeneous. Their symptoms vary between patients and even within patient over time. given the increased prevalence, given the economical impact of asthma, I think accurate diagnosis is very important. And I think just completing the evaluation before starting medication is very critical. If we get patients with a diagnosis of asthma, I think we should always be vigilant about confirming it. It's fairly safe to confirm. And all the time, I think when patients are not responding the way we want them to respond for asthma, I think we should always have a secondary diagnosis, exclusion of other diagnoses in mind. Like if this person approach you, I think with the number of hair, with the bronchodilators, the smoking, most likely not asthmatic. I think it's COPD. But thank you.